Good morning. I'm Mark Stewart, and I'd like to welcome you to Day 2 of the Long-Term Care Hospital Quality Reporting Program Provider Training. Just a couple of quick reminders. There are colleagues in yellow shirts who can assist you with anything you may need throughout the day. A list of acronyms is at the back of the right-hand pocket of the folder you picked up yesterday. And I need to mention there's a table reserved up front if you'd like to be close to the screen with the closed captioning. And thank you, Carmen, for so expertly capturing all of our words both days. We're going to start with questions in a minute that were answered from questions submitted yesterday. These were worked on last evening by the faculty, so they'll be covering some of the questions. They'll continue to work today on questions that were submitted yesterday, and we'll end Day 2 both with questions from yesterday and today, so you'll want to be sure to stay for the question and answer session at the end. If there's a question submitted that they do not have time to respond to, it will go to the LTAC help desk, and a response will be written and sent to all the attendees. If you're joining us online this morning, you can retrieve all of the materials at livestreamconnect.com, where there's also a link to submit questions online. If you have any issues with the livestreamconnect.com, you may also go to the CMS channel on YouTube and view this session there. One quick announcement, Ms. Vicki Golab from the Hospital for Special Care unfortunately was unable to travel, so her section will be covered by Jen Farley. Here's a summary of today's agenda. We'll start with Section A, which will be covered by Jen. We'll then do Section GG, Carol Schwartz from RTI, who presented yesterday. We'll have focused review of sections B, C, H, J, and O. We'll then cover, after lunch, LTAC public reporting, which will be Tree Lee from RTI, and LTAC QRP resources, which had been listed as Vicki Golab, but will be Jen. And as we mentioned, we'll end with questions and answers. Jen Farley is Vice President of Quality and a Patient Safety Officer at the Hospital for Special Care, where she works to ensure that all CMS, Department of Public Health, and Joint Commission mandated quality measures are met through standardized data collection and reporting methods. Carol Schwartz from RTI was introduced yesterday. After lunch, you'll hear from Tree Lee at RTI. And as I mentioned, unfortunately, Vicki Golab could not be here today. Some of the general information, all the materials will be posted after the session. Video recordings will also be available on the CMS YouTube channel, and certificates of completion will be provided to everyone on site who has signed in. Just to quickly recap questions, you may continue to submit them via the cards on the tables. Thank you to those who used that yesterday. Microphones in the room are also available. If the presenter has time to take questions, please be sure to say your name and organization. And last, of course, the online submission form that was used yesterday. You'll click on the link, enter the information, select the section that the question is relevant to, click the blue box to submit. We ask that you just put one question per submission, and the next screen, the link will allow you to submit another question online. This is the action plan that was used yesterday by the presenters and will be referred to again today. It's a great way to focus your ideas into steps to help accomplish your goals. We will now start with questions from Day 1, so I will turn it to Carol. I'm sorry. There are two general questions that were submitted that I'll cover before I turn it over to the faculty. First question, Would it be possible to upload the complete presentations with correct answers and rationale slides as they were missing from the original PowerPoint? And the response is yes. The presentations with answers will be posted to the LTAC Quality Reporting Program training website shortly after the training. The second general question, would it be possible to have a test/sandbox setup so we can see skip patterns, etc.? This way we can, in turn, ask programmers to write into our EMR as such. It's too late to go live. However, it helps to just play with and show respiratory therapists/CNs in advance. Response is, thank you for the suggestion. We appreciate the input, and we will take this into consideration in the future. The rest of the questions that there are responses for from yesterday will be handled by yesterday's faculty, starting with Carol Schwartz from RTI.
Thank you. So the first question we'll cover states, how long do you estimate it will take to review medical records for proof of follow-up on prescribed recommended actions by the next calendar day, given that this covers the entire patient stay record? As LTACs, our patients are in-house for at least a month, often longer, sometimes years. The list of medication event examples provided, not to mention all the different types of communication documentation, are exceedingly disparate, drastically reducing the ability of EHRs to capture items for this metric in reports and leaving us with only a manual review. Each facility, so our response was, each facility has varying consensus, complexity of patients, lengths of stays, and methods of collecting the drug regimen review data. As such, it is not possible to state the specific time required to collect data for item N2005. Each facility will determine the method of capturing all data necessary to support coding of the drug regimen review items. Now is the time for action planning for decisions of where drug regimen review data should be located in order to retrieve for the purpose of data coding. Clinical documentation in the medical records is used to support clinical assessment coding. LTAC Care dataset data should be consistent with data reported in the medical record. Our next question submitted was in N2005, if N2005 looks back to the patient's admission, that means a no coded for 2003 at admission, indicating that there was no follow-up at admission. This requires that no also be coded for N2005 at discharge. Is there a way for a hospital to recover on the patient's drug regimen review, during the stay, to be able to answer yes to N2005? And our response is no. Even if only one of the many potential clinically significant medication issues were not followed up in accordance to the drug regimen review quality measure requirement, the facility must code N2003 and N2005 admission through discharge as no. All identified potential or actual clinically significant medication issues were not completed by midnight of the next calendar day. The next question that we will answer is, how would an interruption within the first 3 days of the patient's stay affect the midnight of the next calendar day time frame? If the patient is experiencing an interruption and the LTAC cannot follow up by midnight of the following day, how would N2003 be coded? And our response is, the LTAC provider would follow best practices by conducting the drug regimen review as soon after the patient's admission as possible. The LTAC clinician should follow up with the physician for recommended follow-up actions as close to the time that that potential clinically significant medication issue was identified. In this scenario, if the patient experienced an interrupted stay after the potential clinically significant medication issue was identified, communication to the LTAC physician or physician designee should still take place as soon as possible, even if the patient experienced an interrupted stay. The LTAC clinician should then complete, okay. Yep, I will. Sorry, this version was truncated. Where are we? Okay, thanks. I want to give you as complete answers as possible. So in developing these, we consulted many, and so here's our full response to that one. So the LTAC clinician should then complete the LTAC physician's recommended actions by midnight of the next calendar day. And in this case, that may include communications with the next facility receiving that patient. The next question that was submitted, we answered, reads, does the clinician referred to in section N need to have any particular qualifications? We also received a few other similar questions, so we've grouped this answer to respond to those as well. CMS does not provide guidance on who can or who cannot complete assessment items, so please refer to facility, federal, state policies and procedures to determine which LTAC staff members may complete an assessment. Each facility delivers patient care according to their unique characteristics and standards, for example, patient population. Each facility determines their policies and procedures for completing the assessments in compliance with state and federal requirements. So that said, the goal for the assessment is to accurately reflect the patient's status. Therefore, staff completing the items should have knowledge of the patient's status in these areas. The next question, how would N 2003 and N 2005 be answered if the LTAC cannot follow up on a medication issue due to patient refusal? And we felt that that meant medications in terms of the refusal. So as long as the communication to the physician or physician designee was made about the potential clinically significant medication issue and the actions were taken as recommended by the physician or physician designee and the facility's policy and procedures were followed by midnight of the next calendar day, then items to N 2003 and N 2005 can be coded as yes unless there are any other potential clinically significant medication issues that did not meet the requirements of the drug regimen review quality measure. If the patient refuses to follow recommendations for medication adherence and it is determined that the refusal presents a potential clinically significant medication issue, the clinician should contact the physician or physician designee. Next, the clinician should follow the recommendations from that physician or physician designee for the issue and follow the facility's policy and procedures for patient non-adherence. Our next question came in. Is it required that the two-way communication from clinician to physician and back again be documented? Or is it just recommended for the hospital's ability to code section N? So clinical documentation in the medical record is used to support clinical assessment coding of the LTAC care data set. So this data should be consistent with the data reported in the patient's medical record. Data in the medical record can be documented by appropriate healthcare personnel consistent with facility and state standards. Determine if your LTAC policies and procedures include that coding in standardized assessments. Can only be entered if required actions have taken place regarding specific communications that may or may not be documented. So that might be part of your policies at your facility. The next question is, how do we code orders given prior to urgent emergent transfer to the short-term acute care hospital? If clinical condition requires discharge prior to medication orders being carried out. So our response is, if the patient was discharged before the drug regimen review admission assessment items were completed, then N2001 and N2003 are coded with a dash. A dash value is a valid response for this item. However, CMS expects dash use to be a rare occasion. Next question was, can you please define a physician designee per CMS guidelines, PA, NP? For IRF, will this have to be a rehab MD? Our answer is, please refer to the federal and state licensure regulations to determine which clinicians are licensed to act as a physician designee. And the last question we'll read from Section N is there specific documentation that is required, expected to be found while the medication record verifying that the DRR activities were completed? Or can it be assumed that the DRR was done when 2001 is coded as 0, indicating that no problems were found? And our response is that clinical documentation in the medical record is used to support clinical assessment coding. LTAC care data set should be consistent with data reported in the patient's medical record and can be documented by appropriate healthcare personnel consistent with the facility and state standards. So I will now hand it over to Terry.
Thank you, Carol. Good morning, everyone. And again, thank you for submitting your questions. They were really excellent, and we're happy to provide the responses this morning. So the first question is one from Section I, and the question is, can we just select Code 5, Other Medical Condition, and enter the ICD-10 code even if it is acute chronic respiratory? I just want to be correct with the coding. So in this situation, if your patient has the primary condition category of acute chronic respiratory, you are going to code it as 3, acute onset and chronic respiratory. You're only going to use code 5, other medical condition, if the patient's primary medical condition category is not one of the 4 categories included on the LTCH care data set. And those other categories, or the 4 categories, are 1, acute onset respiratory condition, 2, chronic respiratory condition, 3, acute onset and chronic respiratory condition, 4, chronic cardiac condition. So again, in this scenario, we ask that you would code it as 3, acute onset and chronic respiratory, if that's your patient's primary medical category and condition. That was the only question we had for Section I. I'm going to move on to Section O, which is treatments, programs, and special treatments. The first question is, what is the spontaneous breathing trial criteria or assessment of readiness for SBT? The spontaneous, and the response is, the spontaneous breathing trial criteria or assessment of readiness for the performance of an SBT is determined by the physician and any weaning protocol standards that you have in your facility. The next question in section O, and we received 2 related questions, so I'll read both of those questions and then read the response. So the next question is regarding intubation that occurs after the patient has been admitted to the LTCH. And the question is, if a patient requires intubation within their stay after 48 hours but is completely weaned by discharge, how do we enter that data to CMS? In this case, the patient was not on invasive mechanical ventilation support upon admission to the LTCH because the patient was intubated during the LTCH stay. This means that item O0150A would be coded as 0, no, not on invasive mechanical ventilation support. And this is at the time of admission on the admission assessment. Subsequently, on the discharge assessment, O0200A would be coded as 9, non-applicable, since the patient was not ventilated on admission. And as I said yesterday, patients who are not ventilated on admission are excluded in both ventilator liberation quality measures, so both the process measure and the outcome measure. The second related question to this topic, similar, are patients who are on invasive mechanical ventilation after admission to the LTCH excluded from the ventilator liberation quality measures? And as just indicated, yes, patients who are ventilated after admission to the LTCH are excluded from both ventilator liberation measures. The next question is around the frequency and how the data is captured, if you will. And it was stated that the ventilator liberation quality measures are calculated based on rolling 12 months. Does this mean these are calculated based on rolling 4 quarters? And the response is yes. These measures are calculated quarterly and on a rolling 12 months. The next question regards the criteria for determining weaning prior to discharge. Does the 2 days prior to discharge for weaning include the discharge date, or is it the 2 calendar days prior to the calendar date of discharge? And the response is, it is 2 days prior to the calendar date of discharge, and this aligns with the assessment period for the planned and unplanned discharge assessments. The next related question to this previous question is 2 calendar days does not mean 48 hours, correct? And that is correct. It does not necessarily mean 48 hours. So for example, if a patient was successfully liberated off the ventilator anytime on Wednesday and discharged anytime on Friday, then this would qualify for at least 2 calendar days prior to the date of discharge. The next question, why does the majority of the LTCH care data set elements focus on a 3-day assessment period following admission, while the compliance for spontaneous breathing trial by day 2 of the LTCH stay items focus on a 2-day time frame? And I have to say that the 2-day time frame and the 3-day time frame was a topic of many discussions at our technical expert panels as we were developing these measures. And to just to give you some background information on that, a task force on the subject of weaning from mechanical ventilation, which included international scientific experts and advisors, recommended that liberation be considered as soon as possible for patients to reduce risk of complications and mortality. After extensive discussion, the technical expert panel recommended the 2-day time frame to set a high standard to encourage high quality of care and increase the probability that patients are determined to be eligible for liberation from mechanical ventilation earlier. And the last question in section O is, if a patient was coded as non-weaning at admission, i.e. O0150A equals 2, improved unexpectedly and fully liberated at discharge, then do you code item O0200A with 1 fully liberated at discharge or 9 non-applicable since this patient was excluded from the denominator? And the response is, if the patient was non-weaning on admission, then the patient would be coded 9, not applicable, for item O0200A, since this patient was excluded from the denominator. And so at the time, in this case, at this time when the patient is admitted, they weren't expected or intended to wean during that LTCH stay.
All right, and I'm going to just answer the last question for this session, and then again we'll be answering questions at the end. So section M, skin condition. If a physician refuses to document ulcers as Kennedy ulcers on a dying patient, does the long-term care hospital have to identify these as pressure ulcers? And the answer is, your facility should have a process in place for when there is discrepancy in documentation or disagreement between different clinicians. And whatever that process is, then depending on whether it is documented as Kennedy or not, then that would determine how you would code that area. So that's it for questions.